Alright, so radiographs for critique, and then we're going to do a little bit of a quiz me, and then that's going to be it for the pelvis and femur positioning. So, AP pelvis, non-trauma. Identify obvious repeatable positioning errors, and then non-repeatable errors. So what I'm going to go over is the non-repeatable errors. The non-repeatable errors are you have the entire pelvis, you have the proximal femurs, so that's not repeatable. You want to make sure that you have them centered. Okay, so we can tell that we have a little bit of off-center, so that's a non-repeatable error because we ended up with everything anyway. The obvious repeatable errors is that these legs are not turned in that 15 to 20 degrees, okay? So always remember when you're doing a pelvis, you have to rotate in 15 to 20 degrees so you show that greater trochanter in profile and then you hide that lesser trochanter, okay? So that's very, very important for an AP pelvis non-trauma. All right, so our next one here says unilateral frog leg. So we can already tell it by looking at this that it is not a frog leg. So what hip projection does this represent, or what does it represent? It represents an AP pelvis, okay? So once again, an AP pelvis, and then our repeatable errors, look at those legs again. Those legs again are not rotated in that 15 to 20 degrees, okay? So we're seeing that lesser trochanter. We're seeing that greater trochanter over top of the neck and the head of the femur. So rotate those legs in 15 to 20 degrees. Also, since we took this AP pelvis, we can see a fracture right here on the inferior, superior, and inferior ramus. So that may prevent us from rotating this leg in. Just see what your patient can do and then take the appropriate image for the AP pelvis, and then if it is a frog leg, make sure that you cone down to the appropriate frog leg and make that image. Also, make sure that you have an anatomical marker on there. So, bilateral frog leg, for this one, we can tell that we're not really frog leg that well. On this frog leg, we can tell that it's a child that we're doing. We can also see that the child's hand has come down into this image, and this is something that we're going to have to re-image. We can also see that this gonadal shield is not covering the gonads, should be right here is where that shield should be placed. So the shield slipped and then that hand came down into that femur. So make sure that before you make that exposure, you know that you are well positioned and that your shield is where it should be. So an AP pelvis critique, we're looking for repeatable errors here. So we can see that this patient's hand has come down into this image. We can see this other hand or some kind of artifact on the right one. We're well positioned here. We can see that this ala is open, this one is closed, so there's a little bit of rotation to this right side. So we need to make sure that they are in a true AP position. So repeatable errors. Patient's hands are over the hips. Note the intertrochanteric fracture, which is right here. Okay, so we need to get the hands out of the way. The legs are not intentionally rotated, which is fine. Could be because of this fracture, and then looks like they're favoring this left side as well, so could keep them from rotating their legs in, but do try. Slight rotation to the right, which we talked about with the wings of the ala of the ilium. And then we need to include the rest of this prosthetic, so we may need to come back and image the rest of this prosthesis. So those are some of the critiques and some of the errors that are happening in that image. So this one, unilateral frog leg critique. So the thing I could say about this one is, of course, we're clipping our marker, we're clipping our pubic symphysis, and then we are clipping our the rest of our prosthetic. Okay, so keep that in mind. You want that pubic symphysis The rest of this is imaged well, except for the pubic symphysis, the rest of the prosthesis, and then make sure that your anatomical marker is not clipped. So positioning error, distal orthopedic appliance is cut off, so you're going to use a larger image receptor, which will cause you to pick up that pubic symphysis, pick up that prosthesis, and then also make sure that your marker is included. AP pelvis critique. So this is an AP pelvis repeatable errors. So we're going to go through this again. We have a marker. If this is an AP pelvis, this is the wrong marker. Once again, our legs are not rotated in, so this greater trochanter is over the neck and the head. We're seeing the lesser trochanter. Also, if you look up here, you're cutting off the iliac crest on this patient. So this is not well positioned at all. Also, you are not lined up to your image receptor. You can see right here with the white outline on this image that you're not centered, you're not well positioned on your image receptor. So rotation of the pelvis, there is rotation. This one is more sharp. This one is wide, so there's rotation this way for that patient. Internal rotation of legs is non-existent, so you need to rotate those legs in. If fracture of the hip is not suspected, which it doesn't look like there is a fracture here, so you need to rotate those legs in and then make sure that you're centered appropriately. This centering is too low for this patient. It needs to be centered just a little bit higher. So pelvic fracture, you can see that your acetabulum here is fractured. Okay, once again, your superior ramus is fractured right here. This is an image of Paget's disease, so you can see the speculation of that that entire pelvis and the femur. This is what Paget's disease looks like on an image. Fractures, once again, just kind of showing you what can go wrong. So this is next to or including the SI joints, so the sacroiliac joints, and then you've got separation and fracture of the superior ramus, and then in that pubic symphysis, a little fracture down here. So both sides of the pelvis are have fractures in them, and then the separation of the pubic symphysis. So is there a fracture? So there's a fracture here that you can see. It may be one of those that it may not be a fracture as well, because if you think about it, the way the bones form and the epiphyseal plates, this is an epiphyseal line, this is an epiphyseal line. This looks like it could be, but the displacement of this line, to me makes it look like this here is a fracture. So just kind of visualize that. Look back on your PowerPoint and see the difference in those lines. So there is a fracture here, intertrochanteric fracture right through here, and then your lesser trochanter is fractured right here. So that's an intertrochanteric fracture. Femoral neck fracture, you can see this fracture right along here of the neck. So no matter what you do, you're not going to be able to turn that leg in, and you're not going to want to manipulate this leg much at all. They're going to have surgery and fix that femoral neck fracture. So this is a very good image. The only thing I would do is make sure that you're open a little bit wider to include that pubic symphysis right there. So this one here is a subtrochanteric fracture, so it's below the trochanters, just below the trochanters. And then once again, like I said, make sure that you pick up that pubic symphysis that's missing right here. But other than that, that's a really good image. Marker, you need to have a marker. And if we look back here, we don't have a marker on this one, and we don't have a marker on this one. So make sure that you place anatomic markers appropriately for your images. Okay, so dislocated hip, DDH. So So you can see that here is your trochanter, and here is the head of, or not your trochanter, your acetabulum, and the head of your femur. They are not, the head of the femur has slipped out. We don't know if it is an anterior or a posterior location or superior dislocation. You would have to do a another image of that to see which way that is dislocated. Usually when you do an AP picture like this, they're going to work at getting that located back into that acetabulum, and then you'll come back to take another image to make sure that it has been put back in place. And then this one here on an infant, you can see that the head of this femur here, the way the femur is looking and the head of the femur, it is not in that acetabulum like it should be. So your acetabulum is here, so you've got some dislocation. There's some superior dislocation, but we don't know if it is posterior or anterior dislocation. But you can definitely tell that there is dislocation going on there. All right, so we're going to start some quiz-me's here. There's just a few of them, and then we'll be done with this. So where is the central ray centered for an AP pelvis projection? So AP pelvis, is it at the level of the crest, level at the ASIS, midway between the ASIS and symphysis pubis, or the level of the symphysis pubis? And for an AP pelvis projection, we should know that it's midway between the ASIS and the symphysis pubis. And then also for that AP pelvis, do not forget to rotate those legs in 15 to 20 degrees to hide those lesser trochanters and profile the greater trochanters. So to minimize distortion of the femoral neck for the AP bilateral frog leg projection, the lower limbs should be abducted. So remember when we talked about the different degrees of abduction, there was one that was to minimize the distortion of the femoral neck, and then there were the other ones that the degrees kept increasing on. So for the frog leg, to minimize the distortion, we are going to be at that 20 to 30 degree abduction to reduce the distortion of the femoral neck. So to visualize the head of femur and acetabulum better, an AP unilateral frog leg projection, the lower limbs should be abducted. What? To visualize the acetabulum and the head of the femur better. So to visualize that better, we know that we're going to get to that 90 degree abduction. Okay, so 90 degrees for the head of the femur and the acetabulum to better visualize that. And then what type of central ray angle is required for the AP axial outlet projection for a male patient? Remember, the outlet, male and female, is different. So are we at a greater angle or a lesser angle for a male patient for that outlet? And if we remember, we know that we are 20 to 35 cephalad for the outlet for the male patient. How is the cassette aligned for an axiolateral Danielus-Miller method projection? Is it parallel to the femoral neck, parallel to the greater trochanter, perpendicular to the iliac crest, or parallel to the long axis of the femoral shaft? And if you remember the images of the Danielus-Miller and how that patient is set up on those drawings, we know that we are parallel to that femoral neck with that image receptor. Okay? So which of the following projections is best suited for the patient with limited movement of both lower limbs to demonstrate a lateral perspective of the proximal femur? So we are suspecting limited movement of both limbs. So do we do the Taylor method, the Danielus-Miller method, the Jude method, or the Clements-Nakayama method? And if we remember anything about our trauma patients and we suspect limited movement in both lower limbs, we are going to do the Clements-Nakayama method. Okay, so that is the last quiz-me. That is the end of chapter 7. And make sure that you view these view these videos, go through them, and then follow along with your book, and then follow along with your PowerPoints as well. Let me know if you have any questions. Thank you so much.